What's up, my average med students? Welcome back to another episode. Today we're going to be covering dermatology from the TZANKI Step 2 deck. So go ahead and subscribe and hit the bell icon to be notified of future posts. Happy studying.
1. Annular rash with bright red outer border and partial central clearing is diagnostic for erythema migrans Lyme disease. 2. What is the best initial pharmacological treatment for rosacea? Metronidazole. Avoid triggers, hot weather, spicy food, alcohol, high temperature, etc. 3. A patient presents complaining of pruritus. Physical exam reveals visible burrow marks on the skin and webbed spaces between fingers. You suspect scabies. What is the diagnostic test? Scraping and magnification of the burrows, lesions. 4. Patient presents with swollen, erythematous lower left leg that has sharply defined borders. Physical exam reveals a red, hot, swollen lesion with erythematous streaks. He also complains of fever and chills. What is the most likely diagnosis? Erysipelas. The red streaks are characteristic of ascending lymphadenitis known to be involved with the condition. 5. An 80-year-old patient presents complaining of a pigmented lesion on his face. Physical exam reveals a large, brown, greasy-looking, encrusted pigmented lesion that appears stuck on the patient's face. What is the most likely diagnosis? Seborrheic keratosis, very common in the elderly. 6. A 40-year-old patient has a bullous, blistering disease with oral mucosal involvement. Physical exam reveals a positive Nikolsky sign. What is the most likely diagnosis? Pemphigus vulgaris. 7. Which age group is typically affected by bullous pemphigoid? Greater than 60. Pemphigus vulgaris equals lesser than 60. 8. A patient presents complaining of blistering, bullous disease. Physical exam reveals that the blisters are found in sun-exposed areas only. He has hepatitis C. What is the most accurate diagnostic test? 24 hours urine collection. Increased uroporphyrinogen is diagnostic. 9. A 24 hours urine collection to gauge for increased uroporphyrins is the most accurate test for porphyria cutanea tarda. Which enzyme is deficient in this disease? Uroporphyrinogen decarboxylase. 10. A patient comes in complaining of spots on his skin. Physical exam reveals multiple, small, sharply demarcated patches of hypo and depigmentation on the face and hands. What is the most likely diagnosis? Vitiligo. 12. Is a black necrotic skin lesion seen in patients with Pseudomonas. Ecthyma gangrenosum is a black necrotic skin lesion seen in patients with Pseudomonas. Ecthyma gangrenosum occurs from perivascular invasion and release of tissue-destructive exotoxins, causing vascular destruction and insufficient blood flow, common in neutropenic, hospitalized, or burned patients, or patients with catheters. 13. What is the likely diagnosis in a patient that presents with the lesion below? Patient has a history of renal transplant and is on chronic immunosuppressive therapy. Squamous cell carcinoma (SCC) is the most common skin malignancy in immunocompromised patients. BCC is more common in the general population, typically appears as an enlarging nodule in sun-exposed areas that can become keratinized and ulcerate. May also cause regional neurologic symptoms. 14. What is the likely diagnosis in a patient with a rash that began as small papules and progressed to erythematous plaques with oozing yellow fluid? The patient was cleaning bushes around the house a few days prior to rash formation. Allergic contact dermatitis likely due to urushiol produced by toxicodendron poison ivy, oak, sumac. 15. What are the ABCDEs of malignant melanoma? A. Asymmetric shape. B. Border irregularity. C. Color variegation. D. Diameter greater than 6 mm. E. Evolving. 16. Which demonstrates a classic spaghetti and meatballs appearance. Diagnosis of tinea versicolor is confirmed with co-preparation, which demonstrates a classic spaghetti and meatballs appearance. 17. What is the likely diagnosis in a patient with a firm, mobile nodule on the back pictured below? The nodule does not change shape when pinched at the edge. The patient had a similar bump in the same location months ago, which spontaneously resolved. Epidermal inclusion cyst, benign nodule containing squamous epithelium that produces keratin. Presence is a dome-shaped, firm, freely movable cyst or a nodule with a central punctum seen below if dimples when pinched on the edge, dermatofibroma. 18. What is the next step in management for a patient with a new mole suspicious for melanoma? Excisional biopsy with initial margins of 1 to 3 mm. Features concerning for melanoma include the ABCD characteristics. Symptomatic moles, e.g., itching, bleeding, and moles that look substantially different than the others, ugly duckling sign. 19. What is the likely diagnosis in an elderly patient with a history of significant sun exposure that presents with the lesion below? It is rough and flaky, but does not itch or bleed. Actinic keratosis has a small chance of progression to squamous cell carcinoma. 20. What is the likely diagnosis in a patient living in a nursing facility that presents with a 2x1 cm skin ulcer on the posterior aspect of the right heel and an area of non-blanchable erythema overlying the sacral region? Pressure decubitus ulcers. 21. What is the likely diagnosis in a young adult patient that presents with the foot rash below? The lesions are painful with walking and standing. Plantar warts due to HPV infection. 22. What is the likely diagnosis in a patient with the rash pictured below? It is painful and has been present for months. Hidradenitis suppurativa due to occlusion of folliculopilosebaceous units commonly affects intertriginous skin areas e.g. axilla, groin, and can be complicated by sinus tracts, comedons, and scarring. 23. What kind of rash is commonly seen with toxic shock syndrome? Diffuse maculopapular rash on palms and soles, eventually desquamates rash on palms and soles, mnemonic RICKKSSST, toxic shock R, rickettsia C, coxa hand, foot, mouth K, Kawasaki K, keratoderma blenharegicum, reactive arthritis S, staph scalded skin S, scarlet fever S, secondary syphilis. Since there is no test for toxic shock syndrome S aureus and blood cultures are often negative, high index. Clinical suspicion is important for diagnosis. 1. High fever, hypotension, shock. 2. Diffuse maculopapular rash covering palms and soles similar to sunburn. 3. Multisystem involvement, thrombocytopenia, myalgias, vomiting, diarrhea, hams, etc. 24. What is the difference between cellulitis and erysipelas? Erysipelas equals upper dermis, raised to marcated edges. Cellulitis equals deeper dermis, flat edges. 26. Rapid diagnosis. Identify actinic keratosis, pre-malignant, scaly papules due to chronic sun exposure, has a small chance of progression to squamous cell carcinoma. 27. Rapid diagnosis. Itching, burning pain followed by eruption of small, red papules, herpes zoster, shingles, reactivation of VZV. Some patients can have neuritic symptoms followed by onset of visible rash. 28. Rapid diagnosis. Papule, nodule with rolled, translucent pearly border, possible telangiectasias and ulcerated center basal cell carcinoma. 29. What is the surgical technique used to treat basal cell carcinoma and squamous cell carcinoma? Mohs micrographic surgery, sequential removal of thin skin layers, loss of only smallest amount of normal tissue, greater than, stop resecting as soon as the margin is cancer-free. 30. Rapid diagnosis. Rapid growing, dome-shaped nodule with a central keratin-filled center. Keratoconthoma resembles SCC. 33. Rapid diagnosis. Skin ulceration that fails to heal in the site of chronic burn wound. Biopsy is most likely to show what? Squamous cell carcinoma secondary to marginal ulcer. Perform punch biopsy. SCC is most often associated with ultraviolet exposure, but can arise within chronic wounds. Scars or inflamed skin. SCC arising within a burn wound is known as a marginal ulcer. 34. Marginal ulcer at the site of an old burn or continuously draining sinus is a risk factor for squamous cell carcinoma. 35. What is Hutchinson's sign in melanoma? Extension of brown, black pigment from nailed to adjacent cuticle. 36. What is the pathogenesis of hidradenitis suppurativa? Inflammation of the hair follicles. Used to be thought that it was infection of apocrine glands. See NBME question below, but now follicle-centered theories are supported per up-to-date varied clinical manifestations. Abscesses with openings to the skin, sinus tracts, comedones. 37. What is a key distinguishing feature of dermatofibroma on examination? Central dimpling when pinched buttonhole or dimple sign. 38. Rapid identification. Erythema marginatum, acute rheumatic fever. 39. Rapid diagnosis. Ichthyosis vulgaris, inherited skin disorder with diffuse scaling. 41. Hepatitis C and estrogen therapy. The risk factors for porphyria cutanea tarda include increased hepatic iron stores, hemochromatosis, alcohol, hepatitis C, and estrogen therapy. Findings include increased fragility of sun-exposed skin, blistering photosensitivity, hypertrichosis, and hyperpigmentation. Diagnosis equals urinary uroporphyrinogen, Inc., in blood porphyrins. 43. The patient presents with a foot ulcer seen below. She had a stroke 3 months ago and now has residual hemiparesis. Current medical problems include hypertension, diabetes, hyperlipidemia, coronary artery disease, and dementia. What is the most likely cause of this patient's ulcer? Pressure decubitus ulcer. While this patient is a vasculopath, they commonly present on the tips of the toes. This patient has dementia and impaired mobility with her hemiparesis, making pressure ulcer more likely. 46. What is the next best step in a young female who presents with skin lesions? See below, and pain in her ankles for the past week. Chest x-ray. Pretend those are a female's legs showing erythema. Not awesome. Also seen with IBD, strep pharyngitis, fungal infections, histoplasmosis, coccidioids, TB, IBD. 47. What areas are affected by hidradenitis suppurativa? Acne inversa. Areas of folded skin, axilla, groin, thigh, perianal. 48. What is the most like diagnosis in a patient with recurrent cellulitis who presents with lower extremity edema? Exam is positive for Stemmer sign. Lymphedema. Inability to lift the skin on the dorsum of the second toe is highly specific for lymphedema. Called Stemmer sign. Progressive deposition of subcutaneous collagen and adipose tissue leads to firm, thickened skin and non-pitting edema. Recurrent inflammation. Cellulitis is a risk factor. 49. What is the next step in a patient with no ABCDE features of melanoma but a positive ugly duckling sign? Biopsy. Features concerning for melanoma include the ABCDE characteristics: symptomatic moles, e.g., itching, bleeding, and moles that look substantially different than the others. Ugly duckling sign. 50. What is the drug of choice in a patient with cervicofascial actinomycosis who has a penicillin allergy? Doxycycline. 51. What is the treatment for purulent cellulitis? Vancomycin requires MRSA coverage.